We're going to talk about clinical trials with you and what these kinds of trials are. Perhaps you could tell us about the Children's Oncology Group and how that group facilitates cooperation.
The Children's Oncology Group is the largest consortia devoted to the care of pediatric oncology patients in the United States. It's comprised of multiple individual institutions, all united towards a common goal. And these institutions are in every single state throughout the US. It's the only way, as I mentioned, we in pediatrics can study these rare diseases. The Children's Oncology Group goal is to create a prospective clinical trial for each individual disease. And so by that, I mean for patients affected by brain tumors, there are multiple brain tumor clinical trials. For patients affected by bone tumors, there's a bone tumor committee and clinical trial. And for patients with liver tumors, we likewise have a liver tumor committee. And so each time we create a clinical trial, we accrue patients for up to a decade, and then we generate the data from the prior trial. We determine what worked best, i.e. what becomes the new standard of care, and we build on that. We ask new questions. We try to minimize toxicity and improve outcomes for patients with difficult to treat disease. The most recent clinical trial was probably the greatest feat yet, in the sense that it was intended to be an international trial, to not only include all of the sites throughout the US, but our collaborators throughout all of Europe and Japan. And from that was born what we call the PHITT trial. That's the Pediatric Hepatic Malignancy International Therapeutic Trial. And as I mentioned, this was an opportunity to combine multiple institutes throughout the United States, all throughout Europe and Japan. The primary PI of the study is Greg Tiao out of Cincinnati Children's. And as I mentioned, multiple PIs at individual institutions are helping to run and open this protocol. For many years, the Liver Tumor Committee was focused solely on hepatoblastoma, as I mentioned, the most common disease affecting the liver in pediatric patients. But that's very young patients that are affected by that disease, and hepatocellular carcinoma didn't have a home. And so for the first time, myself and Dr. Arun Rangaswamy out of UCSF decided that it was time to incorporate hepatocellular carcinoma into prospective clinical trials through COG. And through the work of multiple individuals, we were granted the opportunity to write a hepatocellular carcinoma arm to this trial. And in our minds, this was an enormous opportunity to not only better understand the complexities of the care of these patients, the epidemiology across the United States, and to identify the true incidence of hepatocellular carcinoma, conventional and, most importantly, fibrolamellar, but also to propose a uniform treatment for these patients prospectively. There are many challenges, as you can imagine. Because we were conducting the study in the United States, Europe, and Japan, we had to choose agents or drugs that we knew could be easily accessible across all nations. And because historically we treated these patients like we did hepatoblastoma, we had a lot of data to suggest that chemotherapeutic drugs were efficacious for some patients. So due to these limitations and our desire to really accrue patients, study how they do with receipt of chemotherapy, and better understand the biology of disease, we wrote the clinical trial to account for two patient populations, those with upfront resected disease and those with advanced disease. And we proposed different therapies in those two arms with the ultimate goal to accrue as many patients as possible and better understand and learn from the treatment of these patients in a uniform manner.
Dr. O'Neill, is fibrolamellar carcinoma part of that so-called PHITT, or Pediatric Hepatic Malignancy Therapeutic Trial?
It is, in fact. And I think that's been debated because folks worry that fibrolamellar carcinoma patients don't respond to chemotherapy. In truth, before writing the trial, we accumulated as much data as possible, not only from collaborators in the US, but also abroad, with regards to their use of particular chemotherapeutic agents and the frequency with which they saw response. And they did document up to a 20-30% response rate for many patients, fibrolamellar included. And so that was really our impetus in suggesting more rigorous study of chemotherapy in these fibrolamellar patients to determine whether we could verify the incidence of response and determine whether it was worth studying more chemotherapy in the future. The reality is the most important principle is getting a patient to a point of resectability. And the best question that still remains is how to get them there, whether it's through standard conventional chemotherapeutic agents, targeted agents, or immunotherapy. And without study, we'll never know the answer.
When you say resectability, Dr. O'Neill, could you tell us what that implies?
Of course. We know that the two most, one could argue the most important principle for the treatment of fibrolamellar patients is the ability to resect or remove all disease surgically, all imageable disease. So the challenge there is our imaging studies are only as good as our technology. So we believe that what we see is all that's there. And I think the reality is there's probably microscopic circulating disease always present that we can't image. So while surgery is of utmost importance, systemic therapy or therapy delivered to the rest of the body is equally as important because we have to treat what we quote unquote can't see. But without surgery, we know we can't cure patients. So if we can remove all disease up front, wonderful. That would be the pie in the sky. But what we really need to do is better study agents that can shrink disease or facilitate an easier surgery. The two have to be thought about in conjunction.
Could you tell us a little bit more about how patients and families can get information about the PHITT trial and who's eligible to enroll?
Absolutely. Any institution affiliated with the Children's Oncology Group, which is the vast majority that treats patients, pediatric patients with cancer, will have access to and information about this trial. And so I would strongly suggest that patients and families look at all available options and ask their providers specifically about this clinical trial. The eligibility criterion is fairly broad. Any patient less than 30 years of age. And as I mentioned, patients both with resectable disease at diagnosis as well as advanced disease are eligible. There are, of course, criterion regarding laboratory eligibility and things of that nature, but we tried to keep the trial as broad as possible to not only encourage, but allow as many patients as possible to be eligible for enrollment.
Dr. O'Neill, in looking at some of the details of the trial that you've been describing, it's primarily a trial of different combinations of chemotherapeutic drugs and at least one targeted drug for hepatocellular carcinoma. Could you tell us a little bit about the rationale for using combinations and what is the study really aiming to learn about different combinations of drugs?
Absolutely. So in order to talk about that, I'll talk a little bit about the historical reference point for this. Pediatric hepatocellular patients were previously treated much like hepatoblastomal patients. And so we have a decent amount of data regarding the chemotherapeutics alone. Interestingly, our German colleagues combined chemotherapy in a very small study with a drug called sorafenib. That's a tyrosine kinase inhibitor that has been very well studied in the adult hepatocellular cancer population as a single agent. And so interestingly, our German colleagues said, well, children are strong. Let's see if they can tolerate the combination. And the reality is children are quite resilient in terms of the combinations of drugs they can and can tolerate. And so their study of the combination of both chemotherapy plus sorafenib showed higher levels of response and perhaps promise towards moving a patient to resectability. However, that was very small patient numbers. So our goal was really to validate that data on a larger scale, to better understand the signal that our German colleagues saw and determine whether this was worth pursuing going forward. So the clinical trial as it currently stands for patients with resectable disease up front, we first seek to determine whether they have a normal underlying liver. If the patients have an abnormal liver or predisposition to hepatocellular carcinoma, they go into their own category. But patients without a predisposition, i.e. conventional hepatocellular carcinoma that occurred on its own, or fibrolamellar carcinoma that have upfront resectable disease, our goal is to give 4 cycles of chemotherapy plus this targeted agent to determine whether rates of recurrence are low and to reduce rates of recurrence. Again, the combination has been proven tolerable in the past, and our goal is to study it more prospectively going forward. For patients with advanced disease, as I mentioned, these are the patients that are harder to cure because it's much more difficult to surgically remove all sites of disease if they have disease spread throughout their body at the time of diagnosis. What we know from limited data, as I mentioned, from our German colleagues, is that the combination of sorafenib plus chemotherapy was fairly efficacious, but it didn't get all patients to a surgically resectable state. So our goal for these patients, which we understand to be quite sick at diagnosis at times and with quite extensive disease, was to try and give chemotherapy in a more compressed fashion. So the trial arm for these patients actually randomizes patients to the German regimen versus what we call an accelerated or compressed regimen that not only introduces additional chemotherapeutic agents, but gives them in a tight time frame. We think that's important because the disease can grow fast, and there's a lot of heterogeneity, as I mentioned, between patients. So the goal is to try and deliver as much therapy as we can in a shortened time interval to get patients to the surgical resection they so very need on a short timeline.
Thank you very much for that explanation. I just wanted to ask a general question, which is, are there other aspects of this trial that you'd like to tell people about? And again, why patients would, specifically with fibrolamellar carcinoma, consider enrolling in it?
I think this trial has been an enormous effort of a lot of brilliant minds. I think it's been an absolute pleasure to be a part of. I also think that the individuals engaged in learning more about the biology and better understanding what makes these tumors tick are so dedicated to studying these tumors. And so for fibrolamellar patients that haven't yet had a home, that haven't yet had the opportunity to be treated in a conventional or uniform way with the hope of enhancing or improving outcomes, and with the promise on the back end of perhaps learning more about these tumors that can really substantially influence where we go from here. We need to kind of come together in a scientifically rigorous manner to best understand where to go from here. And my hope is that this trial, as a very stepping stone, may allow just that and allow even more enhanced and focused effort, not only in the US, but in Europe, throughout Japan, of all of our colleagues engaged in this effort.